very much, Tom. I can't think of people that I like more and respect more than Tom, and to have left this place in his good hands is maybe the best thing I did for it. And Deborah is somebody who's trigger smart. Every time I want to really know how much I don't know, I go talk to Deborah, and then I have to think about a whole lot of other things. First thing I'll say is I don't like retiring. I'm handling it, and we need a drink. So I won't repeat that for that, but you can bring it along for me. So, thanks. And what I have found that's good about retirement is that I can be my own researcher, and I can dig into something that I care about and want to think hard about and learn a lot about. And the subject that I've selected, and this is something I've now worked on for really close to a year and a half, is the topic of this paper, Implementing Health Reform. This is the second paper that I've written on the subject. The first one was for a Rockefeller Institute conference in New York City on state finances, and this paper is the second, and I'm already working on a third paper, which I'm going to present in December at the Woodrow Wilson School at Princeton University. Because I've invested so much of my psyche into the paper, I'm going to sort of present the paper and read a little bit of it, not read too much of it, and stick to the script, and there are copies that you can read the whole thing if you wish. The first line of the paper is a theme song of this institute. Implementation is the short suit of American government. Make a new policy and then go make the next new policy. What happened to the one you just made, that's somebody else's business. And besides, we already did that. That isn't going to work for healthcare. It's simply not going to work. This is a tremendous challenge for the society, morally, fiscally, and operationally. I cannot think of a bigger public administration challenge that I have ever gotten close to. And so this will keep me busy longer than I'm probably going to be able to function well, which may have stopped already for a while. So this paper begins with the first section that says, can we implement this law? And the first thing is, no, we can't implement it. I say that it's too much of a piecemeal law and doesn't have enough money, and it doesn't have enough power, and it doesn't have this and it doesn't have that. Go back to the drawing boards. And the Republicans have said that. Other people have said that. Repeal the law and replace it. And Robert Pear had a really fine article in the Times this week about how the Republicans are shrewdly going to try and undermine it because they can't repeal it without having about two-thirds of the votes of the Congress to override a veto, at least for the next 2 years. So that's number one. Number two, can we implement what I said in the paper and what I've thought about is, well, we need, as Senator Tom Daschle said, we need a Federal Reserve Board for Health, insulated, strong body of expert-type people, because the political system can't handle these issues, that position. But that's not happening. It's not going to happen. Wouldn't be bad, in my opinion, if it did. But the political system is going to have to step up to this. And I don't know if we can. I really don't. A famous political scientist, E. Snyder, said, new policies create new politics. There are going to be new politics for the next, it's really 3+ years before the Medicaid expansion goes to 133% in the year 2014, and until the exchanges state or federal or regional, have to be in place and operational. And that's going to add 30 million people, huge demands to a system that already has providers in the catbird seat to raise prices because demands are going up as technology goes up and as people age in our society. And no other country in the world has a system like ours. Fee-for-service specialist in the catbird seat. We spend more than twice as much as any other industrial country, and most of them cover everybody. So I mean, we are up against something very difficult, very special, and I'm an optimist. I believe America is a wonderful country. We can solve our problems. I'm not so sure about this one. This is really eating into our fiber in a time when our political system is terribly pressed and our finances are a mess. Now, the third answer to the question, can we implement, is on page 2 of my paper, and I underlined it, and it's in italics. And I'm going to read that paragraph because it's based on good political science literature and theory about how you implement. You implement gradually. You learn as you go along. You don't plan. Pardon me, but you don't. So here's how to implement the law, in my opinion. Be flexible. Keep an open mind. Implementation is a discovery process. Work hard to discover institutional inventions that has been true throughout American history. The capitalist system has enabled the country to change things. And on that exact subject, I have a presentation time. This is for reference. This is a biography, a wonderful biography of Joseph Schumpeter, the American expert and great theorist who hated John Maynard Keynes and wrote about innovation, about that what is special and powerful in capitalism is that it can creatively destroy things that don't work and invent new things. We have to do that. It's about institutions. It's about systems change. I'll read the rest of this now. View implementation as evolutionary, trial and error. Don't view every decision that has to be made as top-down, governmental, and Washington-centered. States, because of Scott Brown and the Senate needing 60 votes, they had a vote on the Senate bill before he was sworn in. So they voted the Senate bill as the basic bill, and it has the states in the key role for exchanges, Medicaid, and Medicare. It was not what the administration wanted. It was not what the House did. So the states are in this big time. They would have been anyway. Courtney writes about this all the time. But they are, because of Scott Brown, even more so. Make every effort to take advantage of private market structures that could operate for enhancing efficiency and tightening systems. Believe it or not, insurance companies have a problem. If costs keep rising, who the hell is going to buy health insurance? And what employers are going to want to do to fight with them? So employers and insurers are somewhat on the same page. That if costs keep going up, even if the cost estimates in this bill are accurate, which is ridiculous. I just said that right out. Next year, we're scheduled to have a 23% cut in Medicare reimbursements. Now, they never do that. And the Republicans have already said, well, we can't do that. Now, if that bill was implemented the way the Congressional Budget Office said, it would save over 10 years $143 billion. Now, that's not a lot of money in Washington. And that's over 10 years. But even if that happened, even if we did what this legislation envisions, the actuary for the Center for Medicaid and Medicare says that health care will go up to 20% of GDP by 2019 if all of these things could happen the way they're supposed to. The inexorable pressure that has been past and probably will be future is part of the challenge of why we have to develop new systems. And insurance companies, New York Times reporter there, Reed Abelson's been reporting very often on how insurance companies are deciding they've got to change things. They've got to set up policies where networks of providers that coordinate service can work together to cover you like a healthcare home for less than you would pay if you were in a more traditional fee-for-service system. And that is happening. It is, as Deborah will tell us, it's been happening in Medicaid all over the country. Probably 2/3 of the people in Medicaid now are in managed care. And people say we don't do managed care and it's terrible, but we do managed care. And some states, and thanks to Deborah here, we are trying to do it better in New York. So the next thing is not only to take advantage of private market structures that could provide opportunities for efficiency and tightening systems and cutting costs. Constraining costs isn't enough, but it would be good. Work with, not against the states. Some I have a whole section here on states. Some states are on the same page, want to make change, are making change, will run their exchanges in a way that is innovative. Massachusetts, Utah, California has already legislated to set up an exchange, just like Massachusetts, that's not controlled by politicians. And the legislature in New York sets a rate. Some of you are doing that. It's not a good system. Not a good system. So work with, not against the states. Understand the states. If there's any one thing I can teach you about federalism, and I've taught this course mostly when I was at Princeton, it is diversity. States are different. Don't think you can tell them all to do the same thing, and don't think you can treat them all the same way. Consider implementation a continuous process of learning and adaptation. That's the Schumpeter lesson. It happens in a pluralist, capitalist political system, although ours is just at a terrible stage of contention. Keep constantly in mind that there will be surprises along the way. If you're working on we call it, somebody calls it ACA, and I'm on a committee at the National Academy of Insurance, what do you call it? And they call it ACA, which is for, remember this now, Patient Protection Affordability Care Act. The word affordability is in the law. And they ducked the issue mostly legislatively. They did not really want to bite that bullet. They took that Medicare cost reduction and just said, well, we won't do it this year, but then we're going to do it next year. Just wait and see. Keep constantly in mind that there, except from the start, and be alert for opportunities that could have been known in advance. And let everybody know that things that don't work will be changed. Now, that's the key paragraph. And in writing this paper, I correspond with a lot of my friends who are experts, real experts, and I'm not a health expert. And I got encouragement that this is a formula that this is probably the way we have to look at it. At least the people that I didn't expect to agree with me did. And I don't think it's a liberal conservative position, but maybe it is a conservative position. Aaron Wadowski, a political scientist, wrote a book about implementation, wrote it 2 or 3 times. And that's what he said. Implementation is a discovery process. You do it as you go along. Don't think you're going to have a plan and it's all going to be the way everybody's going to march the way you want them to march in the direction you want them to go and succeed. That is not the right mindset for doing this. And I think there's some evidence that the people in this, and I try to, you can find any, it used to be amazing. When I was here, I'd ask somebody to look something up on the computer. Now I look it up myself. And it's amazing what you can find. It's all there. It's all right. I am deeply into this. The next section of the paper is about the American setting. Why is America different? It's not American exceptionalism in the old-fashioned way. America is different because Otto von Bismarck, 100 plus years ago, decided to do this in Germany when there was no system. And so he made a system. That's easier than having a system and trying to change it. The same thing happened with National Health Service, which was 60 years ago. A man by the name of William Beveridge was the social policy expert who supposedly invented National Health Service in Great Britain, and his nickname was Drink. They call him Drink. But when you think about this law, it is incremental, really. It says we're going to use Medicaid, we're going to use Medicare, we're going to use states, we're going to use health insurers, we're going to keep them, we're not going to kick them out the way Canada did. But it is incremental, but it's also revolutionary. It is not just incremental in the old-fashioned way, because what it says is now the federal government is responsible for making sure everybody has coverage. And the word affordable coverage is emblazoned in the law. The best book to read about this law is the Washington Post book called Landmark. They got everything in here. How it was passed, all the provisions of the law, summarized, so it's very hard to read, 2,000 plus pages, but sometimes you do have to do that. And the next section of my paper, I talk about the big elephant. The big elephant is the cost issue. In roaming around in the garden, stamping down on everything. And an economist, a friend of Tom and me and others, Herb Stein once said, if something's not sustainable, it will not be sustained. Well, we've been saying healthcare is unsustainable, but how are we going to do something about it? That is just not easy. The law was, in a way, the easy part. Now comes the hard part. So my philosophers for implementation are Schumpeter and Herb Stein. There are a lot of people playing in this game. I mean, a huge number of things that you can read about it. It's fascinating. But the president's probably appointed 6 people who have responsibility for implementing the law. So there are a lot of people who are maybe working together, maybe not. That's frankly a big question, I think. But there are innovations. We often in America talk about reform while we're doing it. I had a rash recently. I went to the CVS store. I went to the nurse practitioner. She gave me a prescription, and the rash went away. I didn't go to the emergency room. I didn't go to my doctor. Pharmacists, nurse practitioners, and physician's assistants. We have to, there's state laws that prohibit those characters from doing things that they could do. Probably in New York, for all I know. Knowing New York, probably so. I wrote an article which is on the on the Institute webpage about healthcare homes. And it was similar to what I said insurance companies are doing now. They say, we'll make a deal with you. You work with somebody who's going to be your bundler and your coordinator, and we'll give you a deal with a lower premium and a lower cost and a lower copay. And the employers are going to like that. And now that you get health care wherever you are, it's not such a bad idea to do this. It used to be that you couldn't take it with you, but now you don't need to take it with you, because if you aren't covered, you can get covered. So in California, I told you I wouldn't talk about California, but in California, the SPD population, single people and disabled, the most expensive population for public subsidization of healthcare costs have to be in healthcare homes. That's their new system. And I hate to tell you, I don't want to stir Deborah up, the cost figures on New York, you just have to keep going, Deborah. You've got to keep working on systems reform and managed care. And I mean, it's just, I look, I used to work in the budget office, Tom said that. Now I'm reading all of the data from CBO, CRS, CMS, OECD. All by myself I'm reading this stuff. And the thing about it is that the Kaiser Family Foundation, they've got everything out there. They're very good. And they showed 2007, you know, each state, where's New York? And we do a lot, we care a lot, we spend a lot. And I know Deborah changed things, and people around here are changing things, but please keep going. The last section of my paper is called The Politics of Implementation. A philosopher, economist named Mansur Olson once said that as democratic systems get older, the political interests that are powerful become more powerful. They become entrenched. They called it the British disease way back when, but maybe now they should call it the American disease, because the interests that want to protect physicians and hospitals and pharmacies and drug companies, they have real money. I used to work on welfare policy. There was no constituency for welfare people and welfare programs. But there sure is a constituency for not changing things in many of the ways that they didn't change them in the law, and that actually, if they really work with that law, they still could change. Bob Ward encouraged me to write a last paragraph of this study, which is the last paragraph I'm going to read is dedicated to Bob, because I tried to make as strong a statement as I could since I'm old. The liberals who pressed for and deserve credit for passing, it is liberals who pressed for and deserve credit for passing this new law. They should be careful, however. It is being implemented in a time of great political turmoil and fiscal and economic danger. If the implementers of the ACA, do not give high and visible credence and to efficiency and cost containment, they could feed the fires of failure and trigger a weakening, which is going to be fought over a lot, and even, but probably not, at least not the next 2 years anyway, repeal of this new law. So I have discovered that good government has no constituency. And this is what we've got to do. We've got to do good government here. And so I'm not sure about this. I'm really worried. And I'm going to keep working on it. For my paper in Princeton, I've got a new thesis. I told Tom I would say this at the end. And that is one of my favorite ideas, and I think it's right, about American federalism is that American federalism is cyclical. In periods when the country is growing and people care about doing things together, then we do things centrally. It's easier to do things centrally than to do it in every state and in every city. I mean, it's just easier. So centralism and centralization comes in liberal periods. In conservative periods in our history, and this has been true in American history. It was true when Coolidge was president. And he was the strongest, most important conservative president in modern time. And not a dumb guy. But in conservative periods, it's the states that are innovators. It's New York, it's Wisconsin, it's California, it's Minnesota, it's Massachusetts right now. And so we've got to really work with the states and really believe in them and treat them differently. I have a network of 11 states we're working with on a study in Alabama, Louisiana, Texas. There are some states that don't want to play ball, and Virginia are even trying to repeal this law at the same time that they're trying to implement it. I mean, it's a crazy time. But anyway, what I think might be the theory of my next paper, which I now got to start writing because I finished this one, is that we have to look to the states and we have to really dig into what they're doing that is going to make health care work better for people, provide quality care, of course, and do it in a way that changes the structure of that industry. MedPAC Commission, the Medicare Payment Advisory Commission, has been saying for 10 years, we got to bundle and we got to change, but since they have no power, nobody is paying attention to them, although they've said it a lot. But now there is a provision in the law to give power to a group like this, and one for Medicaid too, which the Republicans are already figuring out how they can undermine. So stay tuned. This is some interesting subject.